Hello, everyone. This is Dr. Susan Hudson from Texas Fertility Center with another episode of Fertility Docs Uncensored. I am here with my smashing, spectacular co-host, Dr. Carrie Bedient from Fertility Center of Las Vegas,
Hi.
and Dr. Abby Eblen from Nashville Fertility Center.
Hi.
How are y'all doing? For those of you who are not watching us on YouTube, which you should start watching us on YouTube periodically because we're
You
like
see what we look like.
You can see me
they
in
were
my
both doing
pajamas
little
when we
dances
record.
before they said hi. So I think they were loving being called smashing and spectacular.
Pretty
That's
much.
right.
I don't think
Of
I've ever
course,
been
who
called
who
smashing.
doesn't love being called smashing and spectacular?
Exactly. Talking about smashing and spectacular, what are your favorite types of shoes?
So you have to qualify this. Favorite from a fashion standpoint and look good, or favorite from they're the default ones that I wear because they're comfortable.
One of each.
So I love heels. Like I'm
Very
5'8".
heel fan.
I am 5'8", and I routinely, and I'm not interested in 1 to 2 inch heels. Like I want 3, 4+ inch heels.
Really? Oh,
Oh
no
yeah.
way. No
Because I love
way.
I love being tall, and my husband is 5'5", and so there's never any question of me being shorter than he is or the same height he is. And so at
You're
that point,
always taller than him, is what you're
I'm
saying.
always taller. So being three
Okay.
inches versus 8 inches
What does
taller,
it matter?
it doesn't matter. And
Yeah.
so I have a couple of pairs of heels that over the years I have taken, and they're not like the super expensive ones. I mean, I think I got them at like DSW for $40, things like that, but I've embellished them. So the one that I wore last night was a yellow pair, and I was wearing a blue dress with yellow heels, and then
Nice.
I had put white, they're flat, they're like a yellow cloth covering, I guess is the best way to describe it. And so I took white daisies with yellow, like,
Did you glue them on your shoes?
yeah, and they're really cute. I like them. And I've got
Are
other
the daisies
pieces.
all over, or are they on the like very back of the heel or right on the
See,
side of the heel?
So they're on the back around the heel, and then there's a little ring of them kind of going over the toe.
so you're
Oh,
kind of crafting
wow.
your shoes. You're a crafter. You craft your shoes.
Mm-hmm. I have
Cool.
a pair of hormone shoes that have estrogen, progesterone, testosterone on them. I have a pair of Jimmy Choo lookalikes. They've got an ombre glitter color that I wanted in blue and was not about to pay $1,000 for them. And so I made my own. Um,
Wow.
I have a couple of other pairs too that I've embellished over the years.
That's very
Nice.
cool. So my go-to, oh, what are your go-to comfies?
Oh, flippity flops.
Flippity flops.
Mm.
Okay.
Flippity flops. Yeah.
So my go-to comfies are my Birkenstock tennis shoes, which I love, love, love.
They
And
make
Tennis
tennis
shoes. I didn't
shoes?
know. Yeah, I didn't know they made tennis shoes.
oh my God, I actually have, I have three what I would consider working pairs of them. I have a white pair, a pink pair, and
Oh,
a black
wow.
pair. But my white pairs I replace like every year because they start getting kind of grungy looking and that type of thing. Actually, I'm due to get me another white pair, so I'll probably do that next weekend. Um, but my favorite like kind of feeling good, like looking cute shoes right now, I've gone on this white shoe shopping spree and I don't really know why, but bought a few pairs recently, but they're all like they have a little bit of platform and they've got a heel, which they have to be comfy,
Yeah.
but I too like being tall. I'm 5'7", and these without being like super high kind of let me gain another like 3 inches, which I think is fun too. So
I'm 5 feet and I too like being tall, but I kind of like Carrie said, I'm never tall no matter what I do. So whether I put 1 inch or 3 inches, I'm still shorter than everybody else usually. So I go with the more comfy, less high heels. And I will say, I have a bunch of shoes that I like that are really cute. And I'll go in my closet and I'll be like, oh, those red shoes, they would go so great with this. I'm like, yeah, but they're a little bit uncomfortable. I think I always default to the ones that are more comfortable. But the reason I think I have a fair amount of shoes is we have this place, and I think it's just in Tennessee. It's called Marnie and Liz, and it's awesome because I always like to be that person that likes to find the diamond in the rough. And so it's the shoe store, And they get all these shoes from like maybe a model walked one time on the runway in these shoes, or maybe the whole group was gone and there was one pair left in one size. So if you go on the right day, and I know what the right day is, they'll be putting out sometimes like Cole Haan shoes, and they'll have like, you know, name brand Saucony tennis shoes or Adidas tennis shoes, or you just have to, and they have like hiking boots, they have all the stuff. So it's hard for me to drive to that specific shopping center and not actually also go into Marnie and Liz. And I almost always come out with some pair of shoes, because their shoes are like 25, 30 bucks.
Nice.
Maybe nice boots might be like maybe 50 bucks or something. So it's pretty awesome. So you could embellish all these shoes, Carrie, and you wouldn't have to worry one bit about it.
I think we need a shopping trip in Tennessee.
Yeah.
I would agree with that. I would
absolutely
totally agree with that.
We need to put that on the agenda.
I used to live next door to a store called Last Chance, which was, you know, where there's Nordstrom's and Nordstrom's.
Yeah.
And then there's Last Chance.
Yeah.
And so I got so many like fancy shoes that, you know, had clearly been worn maybe a couple times before, but you know, I was paying 25, 30 bucks.
Yeah.
It was awesome.
Yeah, occasionally they've had designer shoes. Usually they tend to be in the size 6, and I'm not the size 6, but sometimes you can find really nice shoes. But definitely Cole Haan's I found in my size pretty reasonably often.
Awesome.
Susan, your shoes in suede are on sale at Dillard's, just so you know.
Very good. Very good.
Oh,
I have the pink suede. So
it's cute.
they're comfy. Let me tell you. I mean, I wear them all year long. So they're
the pink suede's on sale. So I'm just saying.
Maybe I need to get a new pair of those. All right, let's ask a question. Okay, so our question for today. Hi, team. I love listening to your podcast so much. So I was hoping to get some insight on my recent IUI. I'm 30. AMH is 0.8, and my right tube is blocked for an unknown reason, and I have endometriosis. My husband has low morphology, 2%. I had a recent IUI, and my follicles on the left side measured 26 and 29 millimeters. My husband's count post-wash was 23 million. There is some data out there on Dr. Google that suggests if you have any follicles measuring over 24 millimeters, you don't have a good chance at getting pregnant that cycle. Can you explain why the follicle size matters, and if I have a realistic chance this cycle? Thank you. Carrie
question.
I don't know why that would be the case unless they're going by older data. So the data that we traditionally have gone by is older IVF cycles, because you are really meticulous about knowing what the follicle sizes are and tracking pregnancy rates. And so it used to be when you would trigger in an IVF cycle at 24, 25 and higher, your chances of getting pregnant were really pretty low because you were doing a fresh transfer. And you have to, in a fresh transfer, you have to make the best of both worlds, both the ovaries and the uterus, and that's hard to do. And functionally, when you've got those bigger follicles, your uterus is not as good, and so you end up
your lining's not as good, right? Your lining's not as good.
Your lining's not as good, and so it doesn't stick as well. And so that's the only thing I can think of, because when you truly separate out the follicle size and creating embryos from the transfer and the uterine lining, those bigger follicles are fabulous. And so when you're doing a natural, not a natural cycle, because it's medication induced, but when you're doing a cycle where you're not getting a large follicle number and things are working together in that way, like you should be just fine. Like 26 and 29, that's great. Especially if they haven't ovulated on their own yet, just let it ride. And then when they come out, have sperm there to greet them and go for the best.
I completely agree. All right. So today we are going to talk about things that we usually don't like to talk about as physicians.
We try to avoid talking about these things, actually.
I know we talk about it a lot, but you know, it's not our favorite thing to talk about. We're going to talk about kind of the financial aspects of fertility care. So we're going to break it down a little bit to make this a little bit more digestible, and talk about kind of the beginning part, and then we're going to talk about the treatment part. So we're going to start off with when you first start going to see your reproductive endocrinologist, and you're in the diagnostic phase of your fertility care. So we're trying to get answers. So when we're in the diagnostic phase, how do most people in the United States deal with the implications of that part of the treatment?
So the nice thing about the diagnostic phase is that in general, insurance tends to cover these expenses. Not always,
Mm-mm.
certainly Medicare, Medicaid does not cover anything fertility related. Not all insurances will. But more often than not, you're going to be able to get coverage from your insurance company on the HSG or whatever tubal testing, the uterine testing, the ultrasounds, the saline ultrasounds, the ridiculous amount of blood work that we love to order that is relevant. And we have a lot of people who say, do you really have to order this? Just order the things that are essential. And there's a reason for every single thing we're ordering. We don't want to deal with
Mhm.
tests any more than you want them drawn if they are not going to help us. And so there is rationale and methodology behind all of that. But most of the time, insurance is helpful.
Yeah,
But
and I've not seen anybody lately until this past week. I saw somebody that came in with a group insurer that usually, I mean, I said, "Oh, well, you have da 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 insurance," and I looked and I'm like, "You're right, you don't have coverage. You only have medical coverage." So it makes a difference if they see fertility as a disease or not. And so some insurers will say, we'll cover you for medical problems, but we don't consider fertility as a medical problem. And so the things that Carrie was just talking about, you won't be covered under.
So, what if I come in and I am having other issues other than just having trouble getting pregnant? What types of things might be medical diagnoses that some of these things might be covered under?
Polyps. Any
yeah,
anatomical problems, a lot of times insurance will cover. So tubal issues sometimes, which means laparoscopy. But again, you have
sis,
to cyst, polyps, anything like that,
Heavy
heavy bleeding,
bleeding,
irregular bleeding. Yeah.
good stuff.
uh,
Good.
amenorrhea or lack of periods. I will put in a plug, and this is something I tell my patients when they come in. If I have someone who's coming to me for two reasons, one that's very medical, let's say,
Hmm.
premature menopause, ovarian insufficiency, and for fertility, everything that I write down, we will focus completely on the medical issue first. And we will not go into the fertility part of it at all, because I have found with more than one insurer, if I put both of those issues on the same note, they will
Hmm.
see infertility and they will not cover anything. And
Hmm.
so there are some cases where, I'll put down endometrial polyps that we'll figure out after all the testing. But because I'm an infertility doc, they won't cover it for me, but they will cover it if your OBGYN does the polypectomy, which is not true for every insurer. A
And that's
lot of
got
it
less
depends
and
on the,
less over the last 5 years, I would say.
Hmm.
yeah, I feel like those doc to doc calls with the insurance companies that we do are just, they're stupid. They don't make any sense unless you're the insurer trying to save money. And I feel like I'm
Yeah.
still doing a ton of those here.
Okay.
Well, and the one thing else,
As much of that in Texas as I used to.
Good.
the one thing I'll say too, just realize it puts your doctor in a difficult position sometimes because I've had patients that have come to me and said, "Oh, can you just say that we're talking about this and not this?" And I mean, that's kind of tricky because that's kind of insurance fraud if we lie about what we're doing. And so, like Carrie said, it's one thing to primarily talk about one issue, bill for that, but we can't really say we're not talking about infertility if we're talking about infertility, because that's kind of insurance fraud. So we walk that line too. We want to help you out, but we also don't want to, do something illegal.
Now, an important thing to know when you are going into this diagnostic phase, because a lot of our patients don't go to the doctor on a regular basis because they're young, healthy people and they don't have
Mhm.
to deal with doctor's visits very often, that most people have some sort of deductible and copay that you have to pay even though you have insurance. Okay. And that's something real important to be prepared for, because when you go into your fertility doctor, we're going to order all these tests that we mentioned, and you are going to make a big step forward in completing your deductible. Okay. And if your deductible is $500 versus being $5,000, that's something for you to keep in mind, that those things are going to happen. So, somebody may come in and be like, okay, we're going to have the new patient visit and we're going to have the ultrasound. And they're like, well, how much am I going to have to pay? And that could be several $100s for both of those together in the same day. And people are like, oh my goodness, why is it so expensive? And it's because a lot of our patients haven't met their deductible. And once they meet that deductible, those types of services become much, much less expensive.
Yeah, and just essentially to put it in the nuts and bolts, if you've never dealt with a deductible, it just means you're paying everything out of pocket until you got to that $500 mark or that $5,000 mark or whatever. So it feels like you don't have insurance, even though you do, but you have to come up with that cash on hand immediately when you're at the office.
Sometimes insurances will fuss at paying for two things on the same day. And so there are times where, I know full well, yeah, I could potentially do both the tube test and, a physical exam, whatever it is, on the same day, but insurance will only cover one of it, which means you're paying out of pocket for the other. And so even though it's a little more inconvenient to say, all right, come back this day and this day, it means your insurance is going to cover both of it, which is why we do that. It's not to inconvenience you. We do love seeing your bright, shiny face, but that's some of the logistics that we have seen that impact people. So we want to avoid that.
Absolutely. Absolutely. Anything else about the diagnostic phase that we should cover before we hop into when we're looking at treatment?
I mean, we try and prepare people ahead of time before they come in about what they're probably going to be paying for when they come for the visit. So they'll be prepared. But it doesn't ever hurt for you to call the insurance provider and go, hey, listen, I'm going for an infertility visit. Is infertility covered? What kinds of things are covered? And they can give you the lowdown on whether or not you have diagnostic coverage or whether you don't, basically. So be good. The more you know on the front end, the better, I think.
And if you decide to make that phone call, please don't make that phone call when you're in a hurry. Okay. That's going to be a 30 to 45-minute commitment on your part. So just be aware, this is not something to do when you have 10 minutes of extra time and you're about to run out the door to go do something important.
The other thing is that when fertility offices are calling to try and get your benefits, ahead of time or when you're in treatment, whatever it may be, sometimes the insurance company tells us something different than what they've told you. And, whether that's intentional or not, or just someone who didn't really know what they were doing versus not, we're trying to get as good information as we can for you, but we are only as good as what the insurance company tells us. And so sometimes things will be different. And sometimes there are things that we're not going to know. So for example, if the insurance company wants everything to go through a lab company rather than through our in-house labs, we may not be able to tell you the prices of those because that comes from the lab company. That doesn't come from us. And so there are things that can be surprises that, going back and changing codes on things like Abby said, none of us look good in orange. We don't want to go to jail. Insurance fraud is real, and it is very heavily prosecuted because it amounts to really quite a lot of money. And so, we do have to be quite truthful on that because we worked a long time to get these degrees, and it's hard to use them in jail.
Keep on helping people get pregnant.
Yeah.
Absolutely. Okay. All right. Moving on to the treatment phase. So this is the point where you may be looking at doing something like taking oral or injectable medications or a combination thereof, often with IUIs or intrauterine insemination, or maybe looking at something like IVF or in vitro fertilization. Now, the actual decision medically, we're not going to get into that today. Okay. But we're going to talk about kind of the ballpark financial implications of these types of things and how different people fund/finance these types of ventures. So let's start with the lesser expensive options. So if somebody's going to be taking oral plus or minus some injectable medications, because most people are not doing pure injectable medications with IUIs anymore, unless they're tending to be in their 40s. So for the rest of those people, how much, if you're paying cash, would be a general guesstimate? And again, this is going to vary from clinic to clinic, state to state, etc.
So probably for oral medicine, just oral medicine alone is probably going to be around $40. It's not all that expensive to take it. We use Clomid that's been around for 50 plus years, and we use letrozole, also known as Femara, that's been generic probably for about, I don't know, 10 or 15 years. And I think it's the most expensive of the two, and it's about $40. I've had patients that sometimes can get Clomid with their copay, and also actually with letrozole, now that I think about it. So it's a pretty inexpensive route to go, just taking oral ovulation induction medicine.
But how much does a cycle of kind of ultrasounds and your IUI and your medications, just as a general estimate, how much would a cycle of that type of treatment cost at your clinics?
So I would say about 1,000 to 1,200, because you're adding in ultrasound monitoring. So if you do insemination, you're also going to probably do ultrasound. That costs some money. The shot to trigger the ovulation, usually Ovidril or something like that, it's going to run you, if you get it from Miller Pharmacy, it'll be less expensive, but could run you $50 to $100 depending on where you get it. And then the IUI procedure, I think, is around $550, $600, somewhere in that range, to actually prepare the sperm and put the sperm inside the uterus.
Carrie, would that be about what you?
No, I think we're more expensive than that. I think it's somewhere between 2,000 and 3,000. We tend not to do very many plain Clomid cycles. Like if someone's doing Clomid or letrozole with us, almost invariably we're doing the trigger shot, we're doing the ultrasounds, we're doing the insemination, any labs that go with them, all of those things, just because by the time someone gets to us, they tend not to be interested in just the 5 to 9% success rate you get with a plain unadulterated Clomid cycle. So I do think it's a bit more expensive if someone has to pay out of pocket, but we also do more labs and imaging, so
Okay,
that a lot of people do.
yeah, so for us, I would say medications, ultrasounds, IUI, probably going to run between 800 to 1,200. It may be higher if we have to do more ultrasounds, say if maybe you're a PCOS
Second
patient
ultrasound
and
or something.
you
Yeah.
didn't respond as well as we expected or something like that. But I would say 800 to 1,500 would be average.
Yeah.
So there are, when we're looking at IUI cycles, we have people who pay cash. So obviously, you can hear how that can vary from place to place. There are some places that are you're going to have insurance coverage. Now, when we start talking about insurance coverage for fertility treatments, if you do not have insurance coverage for those fertility treatments, who should you talk to? Should you talk to the actual insurance company or should you talk to your employer?
All of the above, but
I was going to say both.
more effective.
Who's actually in control of that decision, though?
The employer.
Right.
Yeah.
So your employer pays an additional amount on their behalf if you have fertility coverage for that kind of specific rider. And so that's important to understand, because a lot of people are like, oh, I have great insurance. I have insurance through blank company, insert Humana, Aetna, Blue Cross Blue Shield, Cigna, whoever you might want to put in there. And understand it's actually not them that's fantastic. It's your employer who has chosen that particular benefit package for you. Okay. Now, when it comes to IUI treatments and you may have insurance coverage, what are some variabilities you've seen in how that can be offered?
So it seems like there's a couple of layers of how insurances structure their actual treatment benefits, which are totally different than the diagnostic benefits we were talking about a minute ago. So one thing that they will do is they will say, we will cover X number of cycles of inseminations. Usually 6 is the most common number. And then once we cover that, that's it. That's all you get. It's just those inseminations, and they count a cycle as, from the time you go through from the beginning all the way to the end. So if you ovulate early and the IUI doesn't happen, the cycle gets canceled. And a lot of times that won't count against you in your limit. Although sometimes you have to fight for the documentation for that to prove to the insurance company this didn't actually count. But there will be some companies that just say you have 6 IUIs, use them whenever you want, however you want. It's across your lifetime. Once they're gone, they're gone.
What's another way that your fertility benefit may be able to pay out for IUIs?
So another person or another group would be a third-party payer like a Progeny or a Maven or a Carrot, and that's a company that your employer would contract with, and they would be the ones that would kind of handle everything. And generally, patients have different plans even with that. With Progeny, for example, I know they talk to patients about pies. And so you may have one pie or two pie or three pies. And so basically if you do things like IUIs, that's a much smaller slice of the pie than it would be if you did something like IVF. But a lot of times you can choose how you're going to use those pieces of the pie. You can either use them just for IUIs or just for IVF or a combination of both.
So another thing that we see is sometimes people are given actually a financial amount of money, not say, you know, you get to have 3 or 6 IUI cycles, but maybe they may say you have $5,000 fertility coverage. Okay.
Lifetime max. Yeah.
Lifetime max. And sometimes that it could be $5,000. It could be $25,000. It could be unlimited. And so when you're starting off your fertility treatment journey, sometimes you might have to sit there and be like, do I want to spend this money for lesser things or hold out and maybe use it for bigger things later on? Okay. And so understanding how much things cost when they're getting billed through your insurance. So generally from your clinics, it's going to be very straightforward. I think where it starts getting a little harder to navigate is when you start talking about medications. So and I'm going to do the best I can to explain how this works with fertility medications. Say your doctor sends in your prescriptions for your fertility medications. If we sent that to a pharmacy down the road, okay, you would go pick it up and you would pay your copay, okay? But there's a certain amount that the drug company charges for that medication. And the amount that drug company charges for medication is not the same as if you were paying cash price for that drug. Okay. It tends to be higher, especially the injectable medications we use. I'm just going to make up numbers, but if we were using a 300 unit gonal F pen, let's just say that if you were paying cash, that's going to cost you about $300. If you're doing it through your insurance allocation for that same 300 unit pen may be $450. Again, I'm making up these numbers, but it's giving you a perspective that you're not necessarily dealing with the same dollar amounts when it comes to your medications if you're having them financed through your medical benefit. So some people might want to do is you may want to be choosing to pay cash for those because what you're actually investing in those medications is less, and using the dollars more for the treatment things that are happening at your doctor's office instead. Did that make sense?
Yeah, that was great,
Yeah,
Susan. I was taking notes
explanation.
too. Well, and to that end, kind of like I'm most familiar with Progeny of all the third-party payers. And with Progeny, I talk with patients about this often. You know, if you have two pies, one pie could include IVF with genetic testing and an embryo transfer, which would be, and again, I'm kind of making this number up, but say $25,000 worth of services and benefits you would get from that. Whereas if you use a whole pie for inseminations, and sometimes it's been as few as 4, but sometimes it's been as many as 6. But essentially, if it cost in my practice, we'll just say $1,000 to do an IUI cycle, and you get 6 shots at it, that's basically you use a whole pie for a benefit of about $6,000. Whereas if you do IVF, you have a much better chance of pregnancy, and you essentially get the equivalent of about $20,000 to $25,000 worth of services with a better chance.
So let's use this as a segue to go into IVF. So if we're talking about doing an IVF cycle for someone who has moderate ovarian reserve, they don't need complex genetic testing, but they're going to do PGTA, what is kind of a general range that you would quote somebody for IVF in your area?
So there's a couple ways that you need to think about how these prices work. One is all in, the other is
soup to nuts, everything, right?
Soup to nuts, everything. And the other is what each component part is. Because, for example, some clinics, you go to them and they'll say, okay, to do IVF with us is $15,000, whatever it may be, 18, 20, 12, whatever the variation is. That's not the whole price,
Yeah,
because
they don't give you the whole deal.
you probably have about 5,000 worth of medications. You probably have somewhere between 5 and 7,000 for PGTA. You may or may not have additional anesthesia fees. You may or may not have additional lab fees in there, depending on how the structure of things.
You may or may not be
Facility
paying
fees,
for
surgery fees.
individual ultrasounds, individual blood draws.
Yeah, and so there's a bunch of ways to work it, and it's not always super clear. Like, I know that for our center, we have at times given people a checklist so that when they're going to price match, they actually get apples to apples, because there will be centers that say, oh, it only costs 10,000 with us. We'll come to find out they're not including your meds, any of your lab work, or your PGTA, and it's the same, if not more expensive. You just have surprise bills. And so you have to consider where do costs for ultrasounds get counted in? Lab work, medications, the facility fees, anesthesia, and intraoperative fees, the embryology lab work that happens, the biopsy, the PGTA,
Embryo transfer.
embryo transfer, all of those things get collected in. And so, embryo transfer, you may or may not be able to kind of ignore. Some people include those. That is the least of all the costs. But the retrieval, getting the embryos, getting them tested, that is a big chunk of money. And so knowing which parts come from where, because there's a good chance it's not all going to come from the exact same place. You may have a lab company, a fertility clinic, and a surgery center that are 3 different entities
And
that are
anesthesia.
all involved in this, and they're all charging. And so, your fertility clinic doesn't have control over those other 2. And so they can help you with their part, but they don't always have 100% of the information on the other 2 parts, and they don't have control over those other 2 parts.
Well, the other tricky part too is medication costs, because if you're a 25-year-old and you have PCOS, you're going to be on a really low dose of medicine. Whereas if you're 43 and you have poor ovarian reserve, or this is like a Hail Mary, we're going to be slamming you a lot of times with medicine, and your costs are going to be way higher than the 25-year-old that has lots of eggs.
But as a general estimate, could you give it within a $10,000 to $15,000 range?
I would say 25,000 for us, kind of all in.
I would say probably 30-ish.
I would say somewhere between $20,000 to $30,000, depending on all kinds of those factors. So when you look at that, you come back to that. If you're paying, so let's kind of go back to the paying cash versus not paying cash. So if you're paying cash, obviously, if you got in your bank account, you can write a check, use your credit card, whatever you're going to do. If you're needing to, what's unique about fertility and financing?
There is fertility and financing. There's a variety of ways you can do it. So you can get grants for places. These are hard. These are not easy to find. Resolve.org is a great place to go looking for that. Livestrong pharmacy companies will sometimes help with medications. There are specific groups, perhaps based on your, religious preferences or ethnic backgrounds, things like that. You can
cancer, no cancer.
Cancer, no cancer, all those things can have an impact. But for most people who don't, qualify for those things, there are financing programs, which are essentially specific loan programs designed for patients going through fertility treatment, where the company issuing the loan, it's not a traditional bank, but they're used to working with the fertility world. And so they understand, okay, there's going to be PGT costs, there's going to be facility costs, there's going to be med costs, all of those parts. And what they'll do is they will work with the fertility center to say, okay, what's going to be the all-in cost for everything for your cycle, and they'll give you that amount, and you finance it the same way you do for a loan. So your credit score makes an impact, and all of your repayment history for other stuff factors in, salary, those types of things. And then they give you interest rates, and they give you, a disbursement of funds, and you repay at whatever rate you guys agree on.
So a couple of things I'd like to add are, generally your clinic is going to have an arrangement with a couple of these different companies. Okay. So not every clinic accepts financing from every company, and not every company works with every clinic. So that's important to ask, who do you work with for this? And then a little bit about grants. So we have a lot of people who are like, oh, I'm going to apply for every grant I can take a look at. The reality of grants is they tend to be two different kind of playing fields. So one of them I would consider the random playing field. So sometimes there are organizations who have like charity walks, and if you go and participate, then you get so many tickets and a little bingo till, and they draw a number and you win a grant. Okay. And then the other is where you do an application and you tell your story. Okay. For those, there usually needs to be something exceptional in your story other than just infertility. And I don't mean this negatively, but there has to be something in the story that makes you stand out against the other 150 people that are applying for that grant. And so when you're writing those things up, think about what makes your journey unique and share that. That's the reason they're having you write these essays and having you tell your story, is to let them know where you've been and why you want to be where you're going. All right.
Absolutely.
So moving on to kind of the insurance standpoint. So we kind of talked about earlier in the IUI, we have places that, we may have a certain amount of money you can spend. Okay. And then sometimes we have, blank number of IVF cycles. Again, this varies from employer to employer. And then we have these intermediaries like Progeny, where we have smart cycles and that type of thing. How, Abby, you kind of started kind of leaning into this a few minutes ago. How can knowing what your fertility benefits, how they work and what the value of them, how does that play into the conversation with your doctor when you're trying to figure out what should I do next?
So I had this conversation recently. So if you, for example, had two pieces of pie from Progeny, and you could do 6 IUI cycles, which would give you about, I don't know, about a few thousand dollars worth of treatment, or you could use it for IVF, which would give you $25,000 worth of treatment. How would you want to spend your money? And so a lot of times I'll talk to patients about, well, maybe why don't you try paying out of pocket for maybe 3 cycles of ovulation, induction, and IUI? If you're spending $3,000 out of your pocket, then you would have those 2 pies left to potentially do not 1 IVF cycle, but even 2 IVF cycles if you needed to. And so, because you get a much more bang for your buck if you use those 2 pies for IVF than if you used 1 for IUI and then 1 for IVF.
Sometimes you can apply that to retrievals versus transfers too. If you've got the option to do, let's say a retrieval and a transfer, or 2 retrievals, makes more sense to use your benefit on the retrievals because that's more expensive, and then pay out of pocket for the transfers, which is generally a lot cheaper.
Absolutely. Absolutely. Anything else can y'all think about the financial aspects of navigating your fertility care?
I think the more you can understand yourself, and I kind of said this earlier, but the more you can understand yourself, the better. Every now and then I'll have a patient in the office and they'll be like, I'll say, well, I feel like based on your history, you need to do X, Y, and Z. Well, how much is that going to cost? Well, how much is that lab going to cost? Well, how much is the ultrasound going to cost? And, I want to really help the patient. I want to really be able to give them correct information, but on the spot in the office, because of all the variables we talked about, because all the plans are different, your deductibles are different, your employer relationship may be different with this plan versus another plan. It's just almost impossible for us to tell you what those costs are going to be while you're in the office. So it's really is in your best interest to do your homework and figure out ahead of time what you think you're going to pay. And a lot of times the offices can help you with this on the front end, but when you're sitting in front of your doctor, it really kind of ties our hands behind our back, because we're like, well, okay, I guess we don't have to do this thyroid, or maybe we can get it done somewhere else. It makes the appointment a lot less fruitful, because we're kind of talking more about cost than we are talking about why you're there, which is for fertility, evaluations.
Your doc is not going to know the financial answers. They can give you maybe broad strokes, but even then, I've had I tell my patients straight up, I am terrible at the money. I'm great at the medicine, but I suck at the money. And my financial office gets mad at me if I give numbers, because invariably I'm wrong, because some clause will come up of, oh no, this patient has this, and so this is why it was wrong. And then the patients get mad at them, not at me, even though I was the one who was wrong about it. And so your doc is not the right one to ask about this. The other thing to consider is the cheapest treatment is the one that works. Because if you do 6 cycles of IUI, sure, you may have been able to get away with spending, you know, 9,000, 10,000, something like that. But if none of those work and you still have to spend the 25 to 30,000 for an IVF cycle, then that money is not necessarily super well spent. Now, it may be well spent if you really feel adamantly about, I don't want to go to IVF right away, but that ties in some of the mental and emotional, not just the financial. And so these decisions are not always super linear. And a lot of people come in wanting to know, you know, strict success rates and strict dollar costs. That's not how these decisions are made. That may be how they're made on paper. That is not how they're actually made. There's almost always a mental, emotional component to these decisions.
So one thing I wanted to add that just kind of popped in my head that's actually really, really important is realize that if you do have insurance coverage, that some of these companies or some of these policies have exclusions, okay? And the two exclusions that tend to be the biggest and the most sensitive are, one, ovarian reserve testing limits. So there are sometimes that based on your age, your FSH level, your AMH level, that your insurance may say, we understand you have this coverage, but we are not giving you access to it because of poor prognosis. Okay, so that's one thing to be aware of. The other is if you or your partner have had voluntary sterilization. Fancy way to say he's had a vasectomy or you've had your tubes tied. And this kind of ebbs and flows as to whether or not coverage is allowed in those types of situations. But if you've had voluntary sterilization, that is the first question you need to ask, because we have lots of people who are like, oh, I had my tubes tied and I have this amazing IVF policy. And it's like, you do, but this is the number one thing that they exclude from. It's not all policies, and it's less policies than it used to be. But again, this is something that kind of ebbs and flows. And so you need to know, does your policy currently allow you to pursue fertility treatment if I've had voluntary sterilization? So those are two big caveats that like will help you figure out that information, but knowing that on the outside is going to help you better psychologically prepare for what you may have to invest financially.
And I will also say I've had more than one patient who wanted me to talk to the insurance physician because they'd had a tubal ligation or he'd had a vasectomy. They don't care. The insurance companies don't care. No matter what I say, it doesn't matter what I say. If that exclusion is in your policy, that exclusion is in your policy. No amount of talking to the other doctor on the other end from the insurance is going to make any difference at all, unfortunately.
So,
yeah.
Well, I think we have covered a lot of information about something we all try to avoid.
You can just listen to this episode. So now we won't have to talk about it in the office, right?
Yeah, we'll put this episode number just on a sticky note, and I'll just say, oh, here, if you want to know, boom.
There you go. Y'all are always welcome to answer, but remember, we are really good at helping you get pregnant, and there are other amazing people in our offices to help you with the financial aspects.
That's right.
To our audience, thank you so much for listening, and be sure to tune in next week for more, and be sure to subscribe and leave us a review on Apple Podcasts. Would love to hear from you. We're on Instagram, Facebook, and YouTube. Subscribe, stay updated on all things infertility.
You can also visit us on fertilitydocs.uncensored.com to submit specific questions. All of our questions will be answered on our podcast anonymously for the Ask the Doc segment. We would love to hear your questions.
As always, this podcast is intended for entertainment and is not a substitute for medical advice from your own physician. All right, we'll see y'all next week. Talk to you soon.
Bye.
Bye.